everyone. My name is Hamsa Bastani. I'm an assistant professor of operations, information, and decisions at the Wharton School. And my LDI rapid response proposal was on uncensoring COVID-19 infection rate estimates. This was joint work with Osbert Bastani and John Silverholes. So the goal of this project was to get a good estimate of the number of positive cases for COVID-19 in the United States at any given point of time. This is challenging because testing resources are still limited in the US and they're targeted towards symptomatic and high-risk patients. And so the number of positive cases that we're seeing is very likely an underestimate of the true number of positive cases because we're missing out on these asymptomatic and low-risk patients. So we proposed a new statistical methodology to try to estimate the true number of cases, which is a really important input for good policy making. So for instance, a lot of policy decisions are thinking about when they need to institute lockdowns, what kinds of business institutions they need to focus on when instituting these lockdowns. Is it just restaurants and bars or also shopping complexes and so on? And a key input to these parameters are these epidemiological models that require knowledge of how many cases are positive at the moment. So getting a good estimate here, we think is pretty important. So the methodology that we propose actually does learning from other countries where testing is much more widespread. So countries like Iceland or South Korea. And our key insight here was that even though testing is censored in the US, it's only censored for some demographic groups. So among the elderly, we probably have a pretty good estimate of the true number of cases, but maybe not so for younger, low-risk patients. And so we can use the distribution of demographic features of people who have tested positive in other countries to appropriately upweight and debias our estimates so that we can get a good sense of how many true positive infections are around in the US. So a key input to implementing this methodology is actually collecting the necessary data. So none of the COVID trackers that we are aware of were actually collecting demographic factors. And so we actually built a tracker that scrapes data from 34 different states and territories that actually report this information. And we've made this data all open source on GitHub. And using this, we were able to improve our estimates. So for example, in Pennsylvania, we found that the true number of positive cases seems to be about 60% higher than the reported number of positive cases. So other than getting good estimates of the true number of positive cases, we're also pointing out a key takeaway, which is that if governments are not able to test all the patients like they'd like to, they can still help statisticians uncensor these estimates by just reporting more detailed information about who was tested and who was not tested. So if we have enough demographic characterizations of these patient groups, then we can actually uncensor these estimates effectively and overcome the cost limitation of being able to test everybody like we'd ideally like to. Thank you.